Okay. Okay, dearest, good day to every one of us. And it is my pleasure to warmly welcome you to today's webinar on Safe Childhood Begins with Informed Adults. Yes, and on behalf of the organizers, I want to sincerely thank each one of you for taking time to participate in this important discussion. As is already deepened, children depend on adults for their safety, care, and protection. Unfortunately, many children experience abuse, neglect, exploitation, and violence, often in silence. One informed adult can make the difference between continued harm and a child's safety. So today's webinar aims to increase our knowledge, that's you and I, aims to increase our knowledge and also strengthen our ability to recognize signs of abuse and also equip us with practical skills to respond appropriately whenever a child welfare is at risk. So, whether you are a healthcare professional, a teacher, parent, or caregiver, yeah, I believe we have different kind of cadres online here. We have faith leaders as myself at the same time as a health worker. We have social workers as well and community members participating in this. So I thank you all for coming, and I believe you're going to have a successful and a well taught session for today. And let me mention some key housekeeping tips that I would like all of us to okay, there's a notification on the edition that registration did not require. Okay, so somebody is asking that registration did not require MDC PIN. How would the point be uploaded, please? Okay, so I think the organizers will get back to you on that point. So let's take note of these key housekeeping tips, please. Let's try our best to keep our microphones mute unless you are invited to talk. So if you are on it, let me scan through. Please check your distance. I'm seeing, yeah, I think, yeah. So do well. If you're not talking, that's good. I think we've all done very well. And also, questions may be submitted using the chat box throughout the session. And as well, please, let's maintain respect for all participants. And because we may be having differing viewpoints and all that, so let's at least maintain that. And also, because today's discussion involves sensitive issues concerning children, let's avoid sharing identifying information or confidential cases. Yes, if even there is a case you want to talk about, since you've not consulted or you've not taken any legal or permission, let's do well. You can disguise it or clothe it in a way that if even the person is on it, the person will not pick it up, but we can take a lesson from it. And again, let's note that this webinar may be recorded for educational purposes. So please, our organizers, I think so far, I've not seen the recording. So if we are going to record, I don't know whether you wait to, okay, I think recording is on. That's good. So without much ado, we are going to dive onto today's discussion. As we said, today we are going to focus on our theme, Safe Childhood Begins with Informed Adults. Please, my pen is ready. My paper is also ready. If you are going to use any gadget to take down key points and all those, that it will be very, very important. Though they are going to record, but hardly will you and I come back to listen to this audio. So try our best and get some notes down. If you have any questions, as you said, we can drop that in the chat box. So today, we have five key subtopics that we are going to focus on. That is recognizing behavioral indicators of child abuse. So we are going to take a presentation on that and also understanding the different types of harm experienced by children. Then we'll be looking at grooming awareness. grooming awareness and how offenders can gain children's offenders can gain children trust. Then last but one, that is managing disclosures when a child reviews abuse. And the last but not the least, the role of healthcare professionals in child protection. So each topic will be provided, will provide practical knowledge that will help us identify concerns early and respond in a way that prioritizes the child, that's child safety and well-being. So I'm going to call on our first presenter who will be taking us. Please, I'm coming. Let me see. Okay. Okay, so before our first presenter, we are going to take a welcome address by our president, Dr. Hilda Boyi. So please, if Dr. Hilda is on the line, let's welcome her. I don't know how you express that, but Dr. Hilda, we welcome you to take us through the welcome address and also the introduction. Thank you very much. My name is Thomas Akwe, or Reverend Thomas Akwe. I'm your moderator for today. Thank you.
Thank you very much to our moderator. Permit me to leave my video off. My internet has been on and off.
Okay.
So, distinguished ladies and gentlemen, colleagues, healthcare professionals, members of the Pediatric Society of Ghana, good afternoon. So recently on our platform, we saw a comment that was shared by one of our parliamentarians about a child, and many
Doctor,
of us
please. Hello, Doctor, please. It seems the recording has been paused. I don't know whether they intentionally did it. Hello, I said the recording, it seems it has been paused. So can they check on that, if possible? If not, all that you are saying will not be captured in the recording.
Okay, all right. So I'll just mute my sound for now, and then when it comes back. Okay, all right. I think it's back now. It's back now. Yes.
Yes, continue. Thank you.
Okay, so I'll start again. Thank you very much to our moderator. Distinguished ladies and gentlemen, good evening to you all. So earlier this month, one of our colleagues shared a comment that a member of parliament had passed about a child. It was very debatable. Some thought it was okay. Some thought there was a problem with it. And we had several recommendations made on our platform. And the purpose of this essentially is to help to educate everyone so that we are all aware of what child protection means and what is okay and what is not okay. For those who thought that some of the things that were said was okay, thought that, oh, it's common in our part of the world or in our culture to hear people say things like that. And we have a number also disagreeing, saying that it does not make it right. And so today we have put together an expert panel to help us delve into the issues and hopefully educate all of us about the issues around child protection, what is okay, what is not okay, what to do, and the other issues of concern will all be addressed. And it is my pleasure to welcome you all to this very important webinar on child protection, which is being organized by the Social Pediatric Subspecialty Group of the Pediatric Society of Ghana. On behalf of the society, I extend my sincere appreciation to our distinguished resource persons for sharing their expertise with us. The evidence is deeply concerning. UNICEF estimates that about 90 million children alive today have experienced sexual violence, while more than 370 million girls and women worldwide experienced rape or sexual assault before the age of 18 years. And these figures represent children whose health, education, relationships, and futures have been profoundly affected. And the situation definitely demands our attention. The divided nature of the conversation from when it started also shows how important that it is. And we know that approximately 3.4 million children have experienced physical or sexual or emotional and violent discipline. And these all remained widespread. Beyond the impact to the humans, child abuse is also estimated to cost Ghana more than $200 million annually, which is equivalent to about 1% of the country's GDP through healthcare cost, lost productivity, educational disruption, and social welfare interventions. Every child deserves to grow up in a safe, nurturing, and protective environment. Yet, violence against children remains a major public health concern, and it's sometimes overlooked and even normalized, like has been said. And the statistics that I've shared earlier remind us that child abuse is often hidden in plain sight. Many children never really disclose their experiences because they are afraid. They are often also manipulated, they are threatened, or simply do not know how to seek help. In many instances, healthcare professionals are among the first trusted adults to encounter these children. And it places a lot of responsibility on us because we have to be able to tell the difference between right and wrong, what is acceptable and what is not acceptable, to also be able to recognize the signs of abuse and to be able to also respond appropriately, know how to document our findings and safeguard the child, and work collaboratively with the relevant child protection agencies. As healthcare professionals, we often think of child abuse as the obvious signs of physical injury or disclosure. However, many forms of abuse begin much earlier and are far more subtle. They often start with behaviors and comments that society has normalized, asking children to keep secrets from their parents, making inappropriate jokes about their bodies, encouraging unnecessary physical affection despite a child's discomfort, or dismissing a child's boundaries as disrespectful. These seemingly harmless actions can create an enabling environment for grooming and make children more vulnerable to abuse. And I know that many of you on the call now may have encountered a child or two in your years of practice who has come in with abuse or came in with something else, but in your history taking, you recognize that there's abuse ongoing. Child protection, therefore, goes beyond recognizing abuse after it has occurred. It is also about creating a safe environment where children are listened to, where they are respected and empowered to speak up. It is about ensuring that every adult understands appropriate boundaries and accepts responsibility for protecting children. We hope that today's webinar will equip everyone with practical knowledge to recognize behavioral indicators of abuse, understand the different types of harm, identify grooming behaviors, manage disclosures appropriately, and strengthen the role of healthcare professionals in safeguarding children. We all on the call must be advocates for children whose voices are unheard, protectors of those who are at risk, and partners in building systems that prioritize children's safety and well-being. I encourage us to participate actively and reflect on how each of us can contribute to creating safer homes schools, healthcare facilities, and communities for every child. Together, let us strengthen our commitment to ensuring that every child grows up safe, is protected, and is also able to thrive. It is now my pleasure to declare this webinar officially opened. Thank you very much.
That's good. Thank you. Thank you, Madam President, Dr. Hilda. We are very much grateful to have you. And please, if you check the reaction, this thing on your page, yes, if somebody is talking and want to give a clap or anything, you can pick it up. Let me give an example. You get it? Like what is shown on the screen. Thank you very much. So, Dr. Hilda, we are very much grateful for this powerful introduction. And without much ado, we are launching into our topics. We are launching into our topics. And the first topic is going to be on understanding types of harm. And also, we'll be looking at the role of a healthcare professionals. So, and I'm very much grateful and with a great honor to call on our senior specialist, that is a pediatrics, yes, to take us in this presentation. And please all together help me welcome Dr. Adoma Odame to take us through the first presentation, and that will be 25 minutes. Doctor, you are welcome.
Thank you very much, Reverend. I am just taking 1 second to share my screen.
Okay.
All right. Can my screen be seen?
We can see it so in the folder. You've not.
It's still in the folder. Sorry.
Yes,
sorry,
yes. So click on the PowerPoint to showcase for us to see it.
All right. Are we okay now?
I can't tell the others, but my side is still. I'm still seeing the presentation folder with the file inside. That's HAM and the role of a health worker, but it has not shown up yet. Yes. So click on it for us. Everything is gone. We are not seeing anything, ma'am.
Yes.
That one, yes. I know it's not that one.
Yeah, please, we are still waiting on Dr. Adoma to share her screen. So please exercise patience for us. Good, good. We can,
All right. Are we okay now?
yes, we can see it now. Thank you.
All right. Thank you. Sorry for that. So we're going to look briefly at understanding harm and then the role of the healthcare worker. So permit me to start by introducing you to Vera. Now, Vera was a 13-year-old girl who I saw in my consulting room shortly after the COVID period. Within the 9 months that she had stayed at home during the COVID, she had been sexually abused by 4 different people, by a taxi driver, a pastor, a barber, and then a random person that she did not know. She knew the taxi driver. He used to take her to school. She knew the barber. He used to cut her hair. And she knew the pastor. He lived next door to them. The random gentleman, she did not know. However, there's this window of opportunity in this fact that 3 of the people were known to her. 75% were perpetrators known to this child. It's only 1 of them that she did not know. What is the window of opportunity in this? The window of opportunity in this is that perpetrators don't just start out by defiling, by abusing the child. They go through the process of grooming. They go through the process of comments that everybody accepts, everybody trivializes. He gives the child money, he does this, he does that. Lets the child warm up to him till he or she finally take that step and then sexually abuse the child. Let me give you another instance of this young boy, about 4 or 5 years old. And when his mother was bathing him, his mother realized that he said to her, "Mommy, won't you suck my paw-pee?" His paw-pee is his penis. And she says, "Why should I suck it?" And he says, "Oh, when auntie baths me, she always sucks it. So please, you two suck it and then enjoy it." Because this auntie is in close proximity to the child, she's able to groom the child, plant seeds within the mind of the child that it is okay. And then the mind of a child is an interesting thing. The mind of a child believes her that it's okay and then allows her to commit the act. And now is even asking his mother and maybe other grown-ups who may bath him to also commit the act. Grooming is very important. If we are able to tackle that step, we are able to halt that step, then we will be able to rescue many a child who would have gone down the slippery slope into child sexual abuse. Let's take a quick look at a few things, some definitions, understanding harm, and then the role of the healthcare worker. I like this definition by WHO, which says the involvement of a child in a sexual activity that he or she does not fully comprehend, cannot give informed consent to, is not developmentally prepared for, cannot consent to, or does not violate or violates the laws or social taboos of society. People may think that that part, social taboos of society, laws of society, means that then certain things are our culture, it is our custom. That is what we do. It means that some of us may think that then it is legal. It is not. And it does not help the child because it takes the child on that grooming process and then eventually culminates in child sexual abuse. Look at the last point, which says that child sexual abuse may include inducement, coercion of the child to engage in unlawful sexual activity, use of the child in prostitution and pornographic performances and other materials. Also, one very important thing that we must always keep in mind is that a child cannot consent to any form of sexual activity. I have had adults who have, even healthcare workers who have said that, "Oh, he's her boyfriend." This child is 10, and they say that, "Oh, he's her boyfriend." And so it is consent. It is not consent. A child cannot consent to any form of sexual activity. Child sexual abuse is not only physical, it can be contact or non-contact. And these days, we're seeing more and more happening online. And it's important that we as healthcare workers know what we are dealing with. One of the terms that we'll be talking about is adultification, when adults see or treat a child as an adult, and it is wrong. Then grooming will be talked about by the last speaker, so I'll not talk much about grooming. Just that it is the preparatory phase, the lead up of child sexual abuse that the offender uses to gain the trust and compliance of the child. And sometimes they may even gain the trust or compliance of adults around in the family. "Oh, that child is my wife. Oh, everybody knows she's his wife." Therefore, she goes to his room to help him. She goes to his room to clean up. She goes to his room to wash, because what does a wife do? A wife washes clothes for her husband. Then eventually they go down the slippery slope, and then he ends up abusing the child. Types of sexual abuse, we said contact, non-contact, and then online. Now, just take a look at this picture, and I want you to look at the outer circle, the context. You realize that when you have social norms that support child sexual abuse, it actually primes your situation for child sexual abuse. Look at this other diagram, and then look at the outer portion as well. You see your social norms there, and then you see tolerance in the second circle, tolerance of child sexual abuse or sexual exploitation. When we have a society that tolerates it, that trivializes it, you end up having more cases, a higher incidence of child sexual abuse. Let's look at the data. WHO normally says 20% of women, 10% of men. CDC says in the US, 25% of girls and 5% of boys. But some studies by Paul and Kofi Boakye found out that about 33% of children had been sexually abused. 33% of the girls had been touched on their private parts. And about 78% know the offender, the perpetrator. And that is what we call our window of opportunity. In our hospital, our Hope Exchange, we have done some studies, and we realized that in some secondary schools, about 45% of the children, boys and girls, had been sexually abused. And we also did some studies among KIAs, and it went high, up to about 56%. This is an epidemic, and it is something that must be dealt with. What is the real extent? We are not seeing enough, we are not hearing enough, because sometimes children are blamed for their abuse. Child rape myth, oh, the child likes it, the child enticed him, it's the child's fault. And you get even healthcare workers, clinicians supporting these things. The perpetrators are not sanctioned. We don't call them out. What you said was wrong, what you did was wrong. We see the punishment. When those things don't happen, child abuse begins to fester, and then you have more and more cases. Then Boakye said that even when victims find the courage to disclose, sometimes there's collective shame. The family is like, we don't want people to know that our family is the one who is taking this prominent person on. The family of a child who has been abused may say, we don't want to take this MP on, we don't want to take this headmaster on. Otherwise, everybody will know that we are the family who disgraced this headmaster. And they prioritize their name and their dignity above the interest of the child. Let's look at some of the signs. I'll not talk about these ones because I think our clinical psychologists will talk about them. But let's just touch on a few of the physical signs of abuse. So that when you're seeing children in the consulting room, you keep an eye on this. And note that children who have physical challenges or developmental delays are 3 times more likely to be abused than other children. So you may have your sexually transmitted infections. You may have perianal trauma. You may have pregnancy, vaginal discharges. You may have tearing of the hymen, those ones we all know. So this is your normal vaginal anatomy, and then you may have a tear in the hymen. As you can see, from about 4 o'clock to about 7 o'clock, 8 o'clock, that portion in red is where you should normally look out for the trauma or the lacerations in the girl. This is a picture, sorry, I should have mentioned that some of the pictures are a bit traumatic. This is a picture in which you can see the trauma, you can see the bruising. And this is just the end result of what starts with grooming. So grooming is not something to be taken lightly. Certain comments are not to be taken lightly because they are just the first step downwards to a picture like this. In boys are also sexually abused. We may have scarring, we may have tears of the anus, we may have bruising to the urethra, etc. And you can see here that the anus looks nice and tight. Look at your 3 o'clock, your 9 o'clock, etc. Now take a look at this picture. In this picture, you can see that there is anal trauma. Look at the points labeled F. You can see that there's a crack there. You can see that the anus is not very nice and tight. It has been injured by sexual abuse. And then you can see the discharges in the anus, which should alert you to sexual abuse. If you have a boy coming in and the mother or the father says his briefs are pretty offensive, make sure that you don't just treat it surface view. Examine. Find out what went on with the child, because these things are not normal. Any society that trivializes child sexual abuse will end up with a case like this. 15-month-old Farida, who was sexually abused on the 31st of December at a prayer camp. Because as a society, we trivialize certain things and we just let things go. So in a number of cases, you will not see anything. So all that you have is what the child is telling you. That is what you have to use to make a decision and to inform your social welfare, inform DOVSU, and then let the case escalate. How do we interpret harm? Now, remember that trauma affects brain development and stress response. And in children, the brain is developing. So anything that hampers or interferes with brain development will end up on a lifelong trajectory, will end up with lifelong challenges. And what are some of the harms that these children may face? You have the injuries, and I showed a couple of pictures of the injuries and the STIs. And even CDC says that chronic conditions later on in life, heart disease, obesity, cancer, are all found to be related to child sexual abuse, violence against children. When it comes to the psychological harm, your anxiety, PTSD, your shame, and then your guilt. And emotional harm, low self-esteem, difficulty trusting others. I have a very good friend who was sexually abused by a very prominent person in Ghana when she was a child. And till this
It seems you've lost Dr. Okay, she's on it. Dr. Aduma, please, can you hear us? Hello, Dr. Aduma, please, can you hear us? Oh. She's on it, but we are not hearing her. The point she's coming out with is so great, and I don't know how to describe it. A lot is going on, and possibly most of them is being swept under the carpet. Dr. Aduma, please, can you hear us? Oh. Please, can someone hear me on the page? Can someone hear me?
Yes.
Yes,
Okay.
we can.
Okay. Wow, we have 10 minutes of her time, but organizers, please, can you contact her behind the scene for her to check up? Dr. Hilda, please, can you hear us?
Hello. Yes, we'll sort it out. We are sorting it out. Thank you.
Okay. So please, let's all exercise patience a bit as we work on that. Thank you very much. Yeah, so we are still waiting on Okay, I think she's off. So by when she joins, we'll be able to hear from her. And we've not gotten anywhere, but even the aspect of understanding the types of harm, the role of the type of harm, crampon, I tell you, so devastating. And it's so unfortunate to hear the corporate involved in all this. We pray that we will fully get understanding and stand for the rights of these young ones.
The next presenter is ready. Can we take that one rather? Thank you.
Okay. So please, is the next presenter ready? That's Dr. Neely. Are you with us? Doctor, please, are you with us?
Yes, I'm actually signed on as Emmanuel Opon.
Okay. So Mama will be taking us through managing disclosures. Right, Mom? I think that's it.
Yeah, I wasn't actually quite sure what I was supposed to be talking about, but yes, managing disclosures.
Yes,
I haven't prepared a PowerPoint because I don't want you to die by PowerPoint. As a saying we say, death by PowerPoint presentation. I'm not letting that affect you here.
Okay,
I'm talking freely.
Okay, then
managing
we are ready for that.
It usually comes to people and healthcare workers in particular as a shock if they're not prepared to hear this from a child that they have been abused. The child is not going to use the word, "I've been abused by X, Y, and Z." They have so many terms that they use. Oh, so-and-so touched me. What do you mean by touch you? And then they may go through the process, or they may just shut up altogether. So it's important that as health workers, we should be very much on the alert that anytime you're dealing with a child, maybe taking their blood pressure, listening to their chest, whatever, especially if you've had to look at their genital area for whatever reason, a child may come through and say so. There are, and I'll give you an example. Some time ago when I was working, there was a child that used to come to A&E, always with abdominal pain. We couldn't find anything wrong with her, send her home. Next week, she'll come with abdominal pain. And one day she turned up with a bruise on her leg. The only thing is, this bruise was not a bruise. She had colored that top of her leg. And I'm working in the UK, it's likely to be a white girl. And this is a white girl who has shaded the top of her leg with slightly pale blue ink. That looks suspicious to me. So what did I do? I got a piece of white cotton wool, wetted it, and rubbed it, and it came off. And I said to the child, "Hey, excuse me, did you say you got this bruise?" "Oh, yes. And instead of challenging her to say, "Well, no, this is a colored pen or whatever," I said, oh, that's a really strange bruise that you've got there. I wondered how it came about. You see where I'm going with that? I didn't confront her to say, no, you're lying on it. I said, I wonder how it came about. And then she disclosed that, oh, that's where Uncle so-and-so hurt me some time ago. It was at that point that the penny dropped with me. Now, I'm a consultant pediatrician. I was then. Oh, this is why this child keeps coming to A&E with this sort of thing. She wanted to disclose something like that to me. Now, why should Uncle so-and-so cause a bruise on her leg? And she didn't know how to say it to her mother, to whatever. But she knew that if she came to A&E, she'll be seen by a sympathetic doctor and so on. And so she colored that top of her thigh with this blue pen, because by that time, the proper bruise had gone. To cut a long story short, it took some time for us to get to the bottom of it, and eventually, we arranged to have her examined sexually. And yes, she had been sexually abused, or she has had been over a period of time sexually abused. She wanted to tell somebody. She couldn't tell her mother, because I think it was mother's brother or somebody that close to the family. As Dr. Adoma has been saying, usually people within the family are doing that. It could be a disclosure to a teacher in the same way as, oh, so-and-so touched me. And in England, somehow within the language, the first thing they tend to say is touched me. And you should take that with a pinch of salt. What do you mean by touch me? They're talking to you in parables. It's all I can say. Okay? Reverend, here you would understand what I mean by parable. Touch me goes a little deeper than that. So you have to put on your psychological hat and say, can you explain that a little further to me, what you mean by touch me? And you hope that the child doesn't shut up at this point. We are usually told, do not investigate yourself if you're not a healthcare professional within the child abuse range, to go and interview the child if it's not going to get you anywhere. You can always say, look, all right, so-and-so touched you, or so-and-so did something to you. Can you tell me in your own words? In your own words, it should be the underlying factor, and the lawyers will tell you the reason why. What do you mean by touch me? Or what do you mean by so-and-so did something to me? And then write it down. And that is the beginning of a disclosure. It's really, really important that at that point in time, you write down verbatim what the child said to you, and so forth. Of course, they have different families have different terms which they describe the genital areas with. And so you need to know within the family what words they use to say so-and-so touched me, so-and-so did something to me, and so on. I had a child that came in the other day, said, oh, so-and-so, somebody again within the family, humped me. And I looked at my colleague and said, what did they mean by hump? Like the dog humps another dog.
Excuse me. We need to have this room for the High Commissioner waiting area.
Right. I'm in a. I won't be long. I'm in a.
We literally need to.
Yeah.
If that's okay.
Yes, in a minute. I'm sorry. I don't know whether they explained to you that I'm in a double whammy at the moment. I'm supposed to be at a Fanti Fest, a festival in London that I'm involved in, and it happened to be running at the same time as this particular event of PSG. And I wasn't going to lose either. I said they should connect me to PSG, which is why somebody had just come in to say the room I'm using is going to be used by the High Commissioner and so on and so forth. But that aside, what was I saying? And then we found out that the humping actually meant that the child had been abused. And the description was that of how the man abused her.
This is reserved for the High Commissioner.
I know. I'll be with it. Yes, I know. I'm aware. And yeah, maybe the High Commissioner can come and listen too, because this is actually talking to Ghana. Very important. Very important. Okay, I'll move somewhere else, and maybe you can hear me there too. Okay.
Thank you.
Okay, then I think we can give you few minutes as you relocate. Yeah.
Yes,
So
I'll relocate somewhere else and.
So as we wait for Dr. Nelly to relocate, I believe you are taking note of all the key things. Let me see. Dr. Aduma, are you online?
Can you pull me somewhere?
You still haven't finished?
No, I
Yes, Reverend, I am.
Move me from the room because they want to put the
Okay.
ambassador. I'm just
Dr. Nelly, please, can you then mute yourself? If possible, can...
Hello? Yes. This is shut.
Okay, Dr. Nelly. Okay, are you going to continue from here? We can hear you. I think you've muted. Dr. Nelly, please, we can't hear you. You've muted.
Before they went up. So she literally holding up for 5
Sorry, we can't, it's not been told by control, they have to.
Okay, so
Okay. Then I think So House, as Dr. Nelly relocates, I don't know if you agree with me for Dr. Okay, yes. So Mama, please, we'll give you time for you to relocate. So let's take Dr. Aduma to complete with her 10 minutes, if possible. Cool.
Thank you. Thank you so much, Reverend.
Okay.
Unfortunately, I didn't realize that I had gone off, so I have no idea where it ended, where I lost you.
Can you bring back the slides?
Okay. Okay, can you see my screen?
Yes, please.
Okay,
Go to
you
the next
saw
page.
all this, right?
Yes.
We did all this, right?
Yes, we were here.
Okay, where were we? Here.
Yes. Go back.
Okay.
No. Okay, I think.
I think
no,
we
go
lost
back.
you where you said your very good friend had been abused by a senior figure in the country, and then you went off.
Yeah, and that was
Okay.
a pastor at the camp. Yeah.
Okay, so the pastor at the camp. All right. So then we were talking about that means we did all this, right?
Well,
Yes.
yeah, the next one after this.
So
Yes.
we're on understanding harm.
Harm,
All right.
yeah.
And that means that we talked about how trauma affects the brain and everything. Okay, then I just have very few to go. So the physical harm, I think we mentioned that. The psychological harm, we talked about it. And the fact that people who have been victims or survivors, of child sexual abuse are more likely to experience a whole lot of emotional and psychological problems, low self-esteem, which also serves as a reason why they will be abused, right? So it ends up being a vicious cycle, okay? And then antisocial behavior. Some victims now turn around and then end up becoming abusers because of what they went through as children. When it comes to the social harm, we also mentioned that Pastor Cerezo, etc., found an association between child sexual abuse and adult attachment anxiety and avoidance. And we said that these children, short-term effects will include things like regression, withdrawal, aggression, sometimes hypersexual behavior that you don't understand why this child is dancing in this manner in church. You don't understand this child's depth of knowledge of sexual issues, behavioral changes, the fear, and then the confusion. Then we also talked about long-term effects, the fact that they have an increased vulnerability to re-victimization. CDC says it's up to 13 times the possibility of them being re-victimized, difficulties with the relationships, even challenges with education and employment, and substance abuse and mental health disorders. Then we said that if the people that we are advocating to, if the decision makers, the policy makers, if they do not want to accept what we are saying about child abuse and the magnitude of trauma it causes our children, let us give them the financial burden that in the US, it cost about 9.3 billion in 2015. That was the total lifetime economic burden of child sexual abuse. And Dr. Hilda earlier on quoted the figures for Ghana as well. This is the burden. It is that much. And you can never quantify the effect on a child. You can never quantify the trauma a child faces after being sexually abused. Then lastly, the role of the healthcare worker. And this is my last but one side. We said that we need to recognize signs of abuse. We know that the child who has developmental delay is 3 times more likely to be abused than any other child. So when you're passing the catheter for this child, when you're changing the diaper on the ward, when you're doing the bedside bath, have a look and be sure that has this child been abused or the child has not been abused. Remember that we need to provide the immediate medical care, like the post-exposure prophylaxis, when it comes to HIV, preventing pregnancy, etc. You need to ensure the child's safety, and you must make sure that the child feels safe. You need to document your findings accurately. And here I mentioned that many a times we only document on the police form the physical things that we see. So if there's no tearing of the hymen, if there's no bleeding per vaginum, then we don't write much. But we forget that this child has regressed. He's now bedwetting. We forget that this child is withdrawn. She's sitting there. She's not talking to anybody. We forget that now this child is biting her nails in anxiety. All these things must be documented because they are evidence showing that this child has had an adverse childhood experience. They may be evidence showing that this child has been abused in one way or the other. You need to coordinate the multidisciplinary care. Sometimes you need to bring in the ONG team. You may need to bring in the plastic surgeons. You must always bring in the child psychologist, the psychiatrist, to help the child go through the trauma that he or she has experienced. And we must always report the abuse. Escalate it to your social worker, to DOBSU, etc. It's unfortunate that many a times it doesn't go anywhere. The parents will go and say, oh, he's a big man. We want to protect ourselves. We don't want to be the family who made this MP lose his job. So it doesn't go anywhere. But it is our duty, the onus is on us as healthcare workers to make sure that the required authorities are noted. I know that in some countries, if you're a healthcare worker and you see abuse, you see sexual abuse, and you don't do anything about it, you are also sort of like aiding and abetting to the crime. So you can also be dealt with. You can also be disciplined. Unfortunately, our laws are a bit more liberal, unfortunately. We don't even have a child sex offenders register. When a teacher abuses a child in school, when a teacher is grooming girls in school or grooming boys in school, what do? Ghana Education Service will just transfer him from the city to the village. He should go and abuse the children in the village. Nobody cares. But we as Pediatric Society, we as healthcare workers, we need to come together and advocate, fight for the rights of these children. Because abuse thrives in silence. Abuse thrives when no one else is looking. Abuse thrives when people are not agitating about it. So it's very good that a lot of people have been calling out this MP, but you realize that from the discussions over the past few weeks, you realize that a lot of Ghanaians don't really see anything wrong with, she's my wife, I'm going to marry her, I'm giving her money because she's my wife, she comes to cook before me because she's my wife, she washes my clothes because she's my wife. And this is a minor that we are talking about. Many people see it as normal. It happened to us, it happened to everybody. We are fine. Why should we be upset? But wrong is wrong. And it's up to us as the Pediatric Society, as healthcare workers, to educate them and let them know that this and this and this are the reasons why it is wrong. Grooming is the first step on your trajectory down to the full-blown child sexual abuse. And we need to provide follow-up care for these children. And we also need to gather data. We need to gather evidence to be able to build these cases. In conclusion, let us make our country a safe place for every child. Thank you very much.
Oh, thank you very much. Thank you very much, Dr. Aduma. Yeah, thank you very much. We are very much grateful. And I think I love how she summarized the role of a health worker in one slide. And that is so beautiful. I believe you are taking note, and we will be receiving your questions in the comment box, or better still, when we get to the time of taking questions, we will allow you to come up with it. Thank you very much. We are we are a few minutes behind time, and because we are trying our best to work within the time, we are pleading with our subsequent presenters to try and be brief for us. Yeah, we know if we allow you are you're going to give us everything. There are a lot that we know you are ready to pour onto us, but because of time, try to be brief a bit for us. I don't know if Dr. Nelly have relocated safely so that we can take brief top up from her. Dr. Nelly, please, are you?
Yes, I've been relocated somewhere else.
Okay, so I think you have a few minutes to add small to us.
Yes.
Okay.
I was supposed to be talking about the disclosure.
Exactly. And that's what you were throwing light on for us. We are on your ears.
That's right. Now, disclosure is very important. It is important actually for health workers to be aware what a disclosure means, to be aware of the words that a child may use, of the way they may say things, and to be very suspicious when they say something, because disclosure doesn't come on a plate, so to speak, served on a plate. It comes when you're least expecting it. And the child might just drop something then like that, like a bombshell. And that is what may waken you and say, hey, so this child that I've been seeing all the time has actually been being abused. You have to be suspicious. It's like an old physician, one of my elder physicians say to me, it's like medicine. If you don't think about it, you will miss it. So think about it. Think about this odd thing that the child had said to you, especially when you're looking at children with disabilities. They don't have the words to tell you. They don't have the means to point you into certain directions, but you have to know what the child means by their normal communication with their parents or their caregiver. So this is where you have to actually, if you're suspecting abuse, you have to collaborate with the parent or the person looking after a developmentally delayed or a non-verbal child, what they are pointing to, where they are holding, how they are holding, whatever part of their body is being abused. That in itself can lead you to the final diagnosis if you are suspecting it. It is so important to be hyper vigilant as a doctor, as a nurse, as a health worker, when you have a child. I mean, we've heard the statistic, how very rampant it is in our society. So you can't be away from it for a long time before you come across some of these. And the thing is, then what do you do with it? I'm very pleased to hear Dr. Adoma's suggestion that you have to get your team together. Many years ago, when I gave a lecture on child abuse at the College of Physicians and Surgeons with Professor Bedu at the time, because I was looking back about 15 years ago or something. At that time, child abuse, we looked at the categories of the major categories of physical, emotional, and all that. Since then, the world has moved on, and we now have the category of cyberbullying, county line, sexual exploitation, and so on. What we're talking about is sexual exploitation now, which is actually the beginning of grooming, part of grooming. And there are certain elements within a child that a doctor should be hyper vigilant about. And it's always the child's behavior. You cannot go away from the child's behavior, because it is the one that is going to tell you how the child actually feels. The unhealthy, inappropriate sexual behavior of a 5-year-old child, for instance, the sudden changes in mood or behavior in school, at home, in church, the change in the family dynamics, the unexplained luxury gifts, for instance, that they might come to your clinic wearing a nice Rolex watch. That, hey, Osimesi, and then why if a pound, now why not you watch him wear? That could be the beginning of your leading to a disclosure, because with that, the child might then spill out a name, because you are the doctor. He or she would not think that you tell anybody that they are being groomed and they had been abused, because they will say, oh, this nice Rolex watch, oh, Mr. So-and-so na demand you, that sort of thing. And then you say, okay, we will have to have a little conversation about this, couldn't we? A child that's turning up in A&E with drug abuse or alcohol abuse is not telling you straight away that I'm being abused, but they are behaving that way because they want to drown their sorrows. They want to cut off what they feel is disturbing them by going down the route of alcoholism. So at the age of 14, turning up in A&E, drunk. Why? Is that a normal behavior? Spending time to sit with them to find out what is actually leading to this sort of behavior will lead you to them disclosing, and then you take it up from there. Same with drug misuse and so forth. Well, STD and pregnancy, well, that's very obvious enough. That can't come from the sky. So what I'm saying to health workers in particular is, one, be hyper vigilant because child sexual abuse, as we have heard other speakers say, is rampant, both in this country, UK I'm speaking from, and in Ghana a lot more. In UK, we have laws, etc. We have systems for moving in, but the systems sometimes fail, and we are no better. In Ghana, this is the opportunity for health workers, as we've heard Dr. Adomaa say, to be advocates for these children. This is the time to find out, if you're a doctor in an area and you suspect this time, who's your social worker? Who can I talk to? Who is the police? Let's find a system that we can save this child. Yes, the parents might not want to go down the road of disclosing the name of this important person who's been abusing their child, but we need to let them be aware that it is their child whose life they are ruining for life, as you have heard Dr. Adomaa say. Okay, I'll stop there because I know you're short of time. Okay, thank you. Hello? Hello? Hello?
Please, we can hear you.
Hello, Doc. We can hear you.
I said, I'll stop there because I know you're short of time because there's another speaker after me, isn't there? Doctors, be vigilant. The child may say something anytime, and if they do, record it. Whatever you do, record it before you even have a gentle conversation with them about what they're saying. Okay. So I said, I'll end here now. If you'd like to call the other, because we want to leave room for question and answer, aren't we? QA system.
Yes, please. Thank you. Thank you very much, Dr. Nelly Ajayi. We are so grateful for your kind words. We would take the next speaker, and we hope to have you for the question and answer time, if you will be available.
Yes, I hope so. Is that going to be in how many minutes about?
That would be Mr. Samuel Fancy. Please, if you're available.
Yes, I should be available within the next.
We were hoping to be done in the next 20 to 30 minutes.
Okay, so within the next, I've got to go out there and I'll be back in the next 15 minutes, if that's all right. I'll rejoin you in the next 15 minutes,
yes,
if
please,
that's all right.
That would be fine.
It's a bit unfortunate that this clashes
Yes,
with
that would be good.
this due that I am at. Yeah, okay, thank you.
Thank you. Thank you very much. So, Mr. Samuel Fancy is a clinical psychologist. We would welcome you to take the next presentation. And please be brief so we can have the last one before the question and answer time. Thank you.
All right, a very good evening to all of us. Just to confirm if you can hear me. Can you hear me?
Yes, please.
Yes, we can.
Yes, I can hear you.
Okay, all right.
We can see your
You can see my slides as well.
slides too.
Okay, all right, thank you so much. Right. So today we're going to have a very brief discussion on awareness on grooming, how to be able to recognize it as health professionals, how to prevent it, and how to respond to the grooming of a child when you get into contact with that. Again, my name is Mr. Samuel Jandopanti. I'm a clinical health psychologist, and then I happen to be a trained child protection officer as well. I work with a school, and every day I'm with kids. aside the fact that I'm also in a hospital. So we get to have interactions with the kids on this most of the time. All right, so in our session today, we're going to understand what child grooming is, how to recognize it, how to identify it, its warning signs, and then understand the role of the healthcare professional, and then how to respond to their responses appropriately. So one might ask, what is grooming? And I think our first speaker and our second speaker mentioned it. The first speaker decided not to talk about it. I appreciate that. So I'm going to throw more light on that. So what is grooming? So it's basically a process where an individual tends to build trust with a child, a family, or an organization to facilitate something that has to do with sexual abuse, exploitation, or manipulation. Now, in grooming, it tends to have a process and mostly begins with building trust. And then you manipulate little by little, or the person tends to manipulate little by little, tends to break boundaries little by little, whether physical boundary, emotional boundary, sexual boundary. And then they tend to add up with secrecy. I mean, don't tell anybody about it. Don't share this with anyone about it. And then with time, they tend to have control over the relationship that they've built with you. So grooming first happens before the abuse even tend to happen. Aside the fact that others can just jump on you at any point in time and just tend to abuse you. When it has to do with sexual abuse with kids, mostly it begins with grooming before it gets to the abuse itself. Now, so to go over the process again, it begins with a perpetrator targeting a child and then start building trust with the child little by little, and then tends to meet the needs of the child. So if maybe the child needs a gift or something related to school or something, gets to provide the gifts or the needs that the child would want, and then would let the child to trust them more. And then little by little, they start isolating the child and then putting stuff in their head little by little. And then from there, they cross your boundaries little. They'll touch you and figure out whether you've probably told an adult about it. If you have not, yes, that means it's an opportunity for them to cross again, and they'll cross again. And then maybe they'll cross a big one and they'll tell you to keep it a secret. Don't tell anybody. And then the child will start keeping it a secret and opening up to other people. And then the main abuse will happen. And then because the secrecy has already been there and isolation has already been created, they have the control and they tend to maintain control over the relationship that they built with you. So it begins with a target and then ends to the abuse, and then finally they tend to maintain the control for the child. Now, what are some of the common behaviors you observe? Some have been mentioned, but let me go through this as well. So groomers or the perpetrators tend to give excessive gifts to the child. Very important and very key gifts that the child needs, and they give it a lot in excess. They give special attention to the child. They will always have the time for the child. And they almost always want to be with the child alone. And as I said, they break your boundaries, especially physical boundaries, little by little, by little, by little. And they make the child feel so special. If a child tends to feel so special with a particular adult, it's a possibility that might be happening. Possibility, not as it is. And then the child will start to undermine their parents. They tend to want to go to the person grooming them or the groomer as compared to their parent. So they'll say, this is my second auntie, this is my second dad, this is my dad, this is my uncle, for this my uncle is my best friend. All those things could be signs that they are being groomed. And then these groomers tend to test whether adults are noticing any form of behavior change with the child as well. So they ask questions, whether from the adult or for the child itself, to figure out whether indeed maybe the other people around are observing or not. Now, let me go further to talk about the sign when a child may be experiencing grooming. So some of the emotional signs, we have emotional, behavioral, and then physical. Some have been mentioned already. So emotional, the child might have low mood, or the child will be very scared of one person or a particular adult that you might have observed. And you know the child to be very confident, but all of a sudden the child has withdrawn and want to keep to himself or herself. The child will sleep in bed for a very long time and wouldn't want to get out of bed and doesn't want to go to school or doesn't want to meet a particular person. Behavior-wise, you tend to observe that the child is now secretive, doesn't share anything with you, doesn't tell you about stuff about their life, doesn't share their problems with you anymore, but rather want to share with the groomer. They tend to have some expensive gifts all of a sudden. They'll have the iPhones and then the iPads and then some dresses and some makeup kits. All of a sudden, they're just having very, very expensive gifts from adults. And then sometimes you observe the children using sexualized language. And they say it outly without being shy or afraid. Physical. Sometimes you see the child physically harming themselves. Sometimes the cuts that you see on their arms, it's not entirely just about psychological. Sometimes it's because they are being groomed and probably their boundaries have been crossed. They have issues with their sleep, whether they oversleep or undersleep and wake up at dawn or in the night and cannot sleep again. Sometimes they do not even like to watch themselves in the mirror because they don't really like themselves anymore. And there might be some injuries that you can't actually explain. So all this might be, or these are signs that shows that a child might be going through grooming. Now, one key thing that the second speaker talked about was online grooming. And this is another key thing that's also happening as well. This is a situation where a child might be groomed, but it's a situation you are not meeting the child physically, but everything tends to happen online. And currently we have a major issue in the world where most children are online, whether playing games or chatting or whatever, AI here and there. So children tend to have or be exposed to all this. Even these days, you observe a lot of live streams on TikTok, and they are quite nasty for a child to be on. Unfortunately, the parents might need time for themselves, so they give their phones and then their iPads to the kids, and by the time you realize the child is already gone and find themselves on some of these platforms. Now, some of the warning signs. Again, you see your child being secretive on their online behaviors. They tend to have a lot of friends, multiple friends. This person is my friend, this person is my friend, that person is my friend, this person is my friend. And this person is my good friend, this person is my friend, this person is my close friend, all that. Different names for the friends that they do have. They tend to receive gifts, as I mentioned earlier. And then you see them late in the night, most of the time still being on their phones, or because there's time differences, they can wake up late in the night to be able to chat a particular person that makes them feel so special. And you see them sharing videos or pictures with other people. You don't know how. By the time you come, the videos or pictures have been deleted, or the person's pictures has also been deleted. You see something happening, but you don't really have evidence to see. One other thing to realize being with kids is they mostly communicate in using numerals or numbers. By the time you realize, they will just state maybe 478 and it has a meaning, but you have no idea what it means. But you can see some of these things on their phones with all the meanings that a child might be the only person knowing. So groomers are also online, and these are some of the warning signs if you want to see that. Now, the second speaker talked about how to approach concerns from the children, and I want to talk more about it a little bit. So when you're responding to some of these concerns that you've observed, when a child is being groomed, a child is telling you about all the challenges going on, please, you have to stay calm. You're expected to listen carefully and note exactly what the child said. You just record exactly as it happens. And I'm hoping that, or we are hoping that Ghana will get to a stage where we have institutions and structures in our organizations where we can follow up to this child protection or safeguarding departments to be able to follow through some of these things, so that it wouldn't be so much of a burden on the person who receives it, because it's not all of us that are also trained to some extent to receive some of this information that we hear from the children. What are some of the things that you are not expected to do? Some of us want to investigate and ask so much questions and so many questions like police officers and FBI agents. We are not there yet. So sometimes when you hear, if the appropriate quarters in your organization, please take it there. or your hospitals, take it there. You don't need to find out who exactly did it and all the details there is about the child and not. Whatever the child gives you the information, please take it as it is and take it to the place that is expected to get it to. And sometimes we want to find out whether the abuse actually occurred or it did not occur. Whatever the child says, pick it up as the truth and work on it and take it to the appropriate quarters. Do not be discussing among your staff. Sometimes you have to ask for some support, but you not be discussing as rumors among each other and be discussing around there. You do not entirely have to promise confidentiality that this, I don't tell anybody about it, I'll keep it to myself. No, you should not be keeping some science information to yourself. And also not be talking about the fact that I won't tell anybody about it between us. No, please don't promise confidentiality. Situations like this, you can let the child understand that, yes, I know this is difficult, but I'll have to let the person who can support you to support you. So let's take it from there. I have about 2 or 3 slides to end it. Also, do not delay the report, because the little thing that might have happened, you might see it to be little, but it might blow up at any point in time, because children do not have words to be able to explain what they are going through entirely. By the time you realize they've probably caused a major harm to themselves that there might not be any way back. So please do not be delaying reports and say everything as it is. Key takeaways. We should understand that grooming is an intentional habit and is gradual. Sometimes it might appear not to be intentional, where an adult will be giving so much support to a particular child, and by the time you realize, because children go or more attracted to places that they feel very comfortable, by the time you realize they are there and your actions have made the child very close to you. It might not be an intentional act of grooming the child. By the time you realize you've already made the child too close to you. But grooming itself mostly have a negative connotation, and most of the time it's intentional by the perpetrators, and it's a gradual process that they do. And it often begins with trust before it ends with the abuse. And children, most of the time, because sometimes they're afraid or they don't have the words to really share what they are going through, or sometimes they don't even know what is actually happening, they tend to disclose this late, not immediately. Early recognition helps to prevent any form of abuse, because it will still be in the process of grooming. And every healthcare professional is an agent or is an ambassador to make sure that grooming does not happen or abuse does not happen. So we should always open our eyes and be vigilant and make sure that some of these things do not happen to us. So thank you so much for the opportunity to share with you. I'll still be available for the questions. And if anyone wants to have any further conversations with me, you can connect with me here. Thank you so much. Am I still audible, please?
Yes, please, you are.
Okay. All right.
Thank you very much. Reverend, please, are you back online? Reverend, please, you can go on.
Yeah, okay, thank you very much. I was trying to come on, but my network was completely gone. I thank God for the opportunity given me once again. Please, it is becoming so interesting. So interesting. And Dr. Nelly mentioned something, and Mr. Samuel also had deepened it, that when a child comes to you to report anything to you, you need to embrace those things with a soft heart. You do not put in emotions to begin diving like a police officer. If not that, you're going to lose that child. Oh, thank you very much. Please write down your questions. We will allow you to come through with that, and our facilitators are ready to answer all. But before we come to the questions and answers, we will go to Mrs. or Miss Louisa Setanam, our clinical psychologist, to take us through recognizing behavioral indicators of child abuse. Yeah, so do we have Mrs. Louisa on board? If she's on board, let's welcome her with an emojis or with a reaction. Yes, that's good.
Hi, Reverend, good evening.
Yeah, good evening.
I believe we can just take the questions and answers because a large number of what I would be discussing has been spoken about.
Okay.
So for the sake of time, let's quickly do that. And I'll be available to answer some of the questions as well.
Oh, okay. Thank you very much, Mrs. Louisa. So please, if you have any question, kindly raise your hand. When you check your reactions, you will see the top sides indicating raise hand. So when you raise your hand, I'll call on you for you to come in to ask your question, or better still, you can put it in the chat box. Yeah, I'm ready to read that so that our facilitators pick that one up for us. Is there anyone asking a question?
There's a question in the chat box.
Okay, let me see. Okay, what do we do when parents blame the child? What general approach should we take to address such issue? There's an issue. It has happened. The child comes to talk about it, and the parent begin to blame the child. As one of our presenters rightly said. Yeah, it's the child who called for it. The child loves it. The child that. So if this happens, what general approach should we take to address it? So any of our facilitators who want to respond to that can do that as we still open up for other questions. Please, who is picking it up for us?
I'd like to.
Okay.
Hello.
Please go on, Mom. We are listening.
If the parents are saying they're blaming the child, I think this is a time where you probably need to separate the parent and the child and maybe talk with them quietly to give you the reasons why the child is being blamed. Often, if the argument is going on between the parents and the child and yourselves, it puts even more pressure on the child. And it's a very uncomfortable position for the child to be in. So I would advise, first of all, that, okay, try and be as diplomatic enough and say, all right, I hear you, Mr. and Mrs. whoever. You think it's a child's fault, and I'd like to talk to you separately. It does require time. It does require having the resources of a different room, for instance, to talk to the parents about. And this is where you begin the advocacy issue. It is important to get the dynamics of what's going on within the home. Not necessarily to deny that, yes, it's a child's fault or it's not a child's fault, but coming right in the middle and say, why do you think it is a child's fault? Let the parents give you their reasons. And then talk to the child also separately, saying, why do you think mom and dad are blaming you all the time? You'll find a lot of things come out. And you begin to unravel this. I'm sure my psychologist friend will understand the situation very well, no?
Okay, thank you very much. Thank you very much. So as Dr. Nelly said, when that begins to happen in your presence, kindly separate both. Separate the mother from the child and take time with a soft heart and with a great open mind, listen and see how you can come into advocate. Thank you very much. Please, any additional or top up to what Mama Nelly presented on the question that was asked in the box?
Yeah, I would like to add up. That's okay. Okay, so instances where, just to add up to what Doc mentioned, instances where the parent is blaming the child, most of the time it happens where the parents themselves might have had some experience by themselves in the past. Or it could be that they are expressing themselves because of the fear for the future, or the fear of what has happened and the consequences that will probably come up with the child. So to add up, the parents should actually have some sessions with you, or you can actually refer the parents or the adults to a psychologist who is available in the facility to provide support for the parent. Sometimes the parents also do not understand the weight that is on the child as well and the repercussions on the child as well. So it's also opened, it's more advisable as well to let a psychologist or a counselor or a mental health professional who is also in the facility to also open the parent up and the child up to how they can manage themselves in that particular situation. Thank you.
Thank you very much. Yeah, and I think this will work when or where the system is actually working, where in the facility you have all the psychologists or the environment, you have all the people available. We pray that indeed it will work in all areas for us to get all the necessary support that we can get for our children. Yes, please, any other question or contribution? Please, when you check the chat box, our organizers have dropped the form for the CPD and also an evaluation form. Yes, we'll be glad you take note and fill that as well so that it helps us to deliver the best for you. Thank you very much. So please, any other question or contribution or anything you want to bring on board? We are waiting. I'm not seeing any hand. We have 193 people on board. Let us hear you. Okay. Dr. Adoma, please, you can come on.
Yes, I would like to ask Dr. Nelly a question. But I think that somebody else has a question in the chat. So maybe let's take that one first, then I'll come back.
Okay. The person said, great presentation by all speakers. Thank you. Please, in a situation where both victims and perpetrators are minors, how can a minor perpetrator be helped as well? That is the first question. So a situation where the perpetrators, that's the perpetrator and the victim, are both minors. How can a minor perpetrator be helped as well? Yes, who is speaking to this for us? Okay, Dr. Adoma, please come on. Dr. Adoma, please, your hand is up, so I don't know whether you are speaking to it or it was just the first.
Oh, sorry, it's the first hand.
Okay,
sorry.
Okay. So please, who is speaking to the question for us? In the case where both the perpetrator and the victim are minors.
Okay, right. So in most situations where both the victim and the perpetrator are minors, you should understand that they both come from backgrounds where you should explore. And again, you will talk about the fact that if the systems are working, and the system have to work in some situations like this to be able to properly support two children or two minors in situations like that. So aside the fact that we have the issues concerning the law in it, both of them will need support psychologically as well. So just like I mentioned earlier with the first scenario, both of them need support psychologically. Their parents or they're finding out where they stay and the environment and their background, you have to get into it as well. And then there should be support for the parenting or the guardian to be able to provide or give them that space that they can share as well. So I think that is one angle you can really deal with. Thank you.
Thank you very much. If there is any addition from another presenter, where both are minors. In addition to that, let's add this one. The person who said that, thank you for insightful presentation. Please, how do you handle cases in which child is being threatened by the abuser? Yes, and this most often when you listen to the cases or you read the cases, you come across this because the person actually did it with a clear conscience. So we'll go to the extent threaten, even to the extent that if you are not careful, I will kill you. If you tell this person, you will die. So in a case like that, how do we handle it, or what should we do? Our facilitators, we are waiting. Let me add the last one to it. Actually, this is my question, and I think the person have asked it in some way. Is there a way we can make writing police statement or form, getting support, including seeing a psychologist, free for families? A lot of families do not push on this because money becomes an issue and the perpetrators silence them with money. And that is the point. When you come to our hospitals, before a doctor will sign police form, an amount of money will go into it. So if the family are in trouble, they don't have money, how do they come by this? Our facilitators put all together and talk to us. You've done very well, but these are issues too that is eating us up.
Yep. It's very disappointing that we haven't moved on in the last 15 years of that issue, because Professor Bedu and I were talking about this about 15 years ago, this very issue, that lack of funds within families means lack of progress for the child. We've got to do better than this. Now that the Pediatric Society is strong, we need to advocate to the government, to whatever, for such funds to be made available. For instance, there was a question where doctors were not being paid for doing extra work, like examining a child who has been sexually abused, if the case came from the police or something like that. I mean, there's so many shenanigans within the Ghana system that we need to sort out. And perhaps this is where the leadership can try and advocate very strongly for us. Having diagnosed it, how do we help these children along? In the same way as somebody can raise the funds to have a cardiac surgery done on a child, a 5-year-old child, maybe we ought to try and put the hat in for funds to be raised to help children like this. That would be my view, but it depends whether people look upon child protection or child sexual abuse as a proper epidemic or not. It is epidemic in my view.
Okay. Thank you very much, Dr. Nelly. I think that's a great, So Mr. Samuel can come in. Okay. Yeah, Dr. Adoma, when Mr. Samuel finishes, then we come on board. Thank you.
Right. So I checked the person who asked the question. I realized that is Dr. Mabel. Yeah, so she's mostly in that space, so she totally understands what she's saying and where she's coming from. I understand. Thank you, Dr. Mabel. So to be able to answer this question, I should clearly state that most of the time in Ghana and the organizations we find ourselves in, we don't take child protection and safeguarding as a culture, but it has to be a culture. If it's not a culture, most of these loopholes will be there. One, we should have a department for child protection and safeguarding. We should have. Safeguarding is the bigger umbrella. where child protection falls under, and the safeguarding, the staff apart. Now, safeguarding and child protection should be a department one. There should be structures that just in case something happens and there's a report, they can follow through a flow chart or a chart flow that can go to this particular department. From the department, they do this and they do that. Now, again, with the flow chart, that particular department should have a connect or should have a link to a lawyer, to aside the law or the lawyer, they should have a link to the police as well. So that just in case there's something happening, a situation like this happening, they know the quarters that they are going to. So we can have this conversation, we can have this share of ideas, but it still comes back to structures, and there should be structures. This is as important as any other department there is that we have in our organizations. So I think it comes back to structures. If not, we will always be taking or be dealing with incidences as they come individually. But some of these cases should not be individually. There should be a continuum. There should be structures that has been stated there. There should be trainings, right? So I'm glad we are having a CPD like this. But aside the CPD, every organization there is, whether hospital, whether school, whether the parliament or corporate or bankers, whatever there is, there should be training specifically on safeguarding consistently and often, at least twice a year, to be able to at least have some of these questions or challenges or gaps be solved. Thank you.
Thank you very much. I think Dr. Aduma.
Reverend, yes. Okay,
yeah.
so I just wanted to address a couple of the questions. One was about the 2 minors, which Samuel talked about.
Okay.
Unfortunately, sometimes when one of the minors is around maybe 15, 16, maybe the boy, and maybe the girl is around 12, and the issue comes up, it goes to social welfare. Social welfare takes it through to DOVSU, and then DOVSU now processes. 1 or 2 that I have seen recently, they actually were planning on sending the boy, the perpetrator, to a correctional institute. It was a bit of a challenge to me personally because I felt that he needed a lot of psychological support, because once a child is abusing another child, it means that that child has been abused. Once you have a child who's sodomizing another child, it means that that child has been sodomized by somebody likely to be an adult. Therefore, he also needs some form of support. But what happened in these cases was that that young man was being sent to a correctional institute. Then somebody asked something about threats. What do you do when the perpetrator is threatening the child? Once it gets established, social welfare is informed, DOVSU is informed. DOVSU actually does very well. They will come in and then with the police extract and whatever, they actually pick them up and then process for court. Sometimes it's very speedy, but other times, unfortunately, the parents will want to bring it out and then settle it out home. But once DOVSU is made aware of the threats and everything, they will hold on to the person so that person will not be free to go and then abuse or torment or carry out those threats on this child. And we do know that a lot of these threats, the perpetrator does play with the mind of a child. He'll tell the child your mother will die because he knows the child loves the mother. Many times they won't say the father will die because sometimes the fathers beat the children. So he knows that if he says the father will die, the child may not mind him. But many times they say the mother will die because the child wants the mother to live. So then the child will keep quiet. Oh, no, you know what I'm talking about, Reverend. So many times, exactly. So many times they'll say that is the mother who will die. And many of these threats, and you will die, etc., they are just playing with the mind of a child. You don't really get many cases in which those threats are carried out. But it's just like Samuel said, they are playing with the mind of a child, all in that grooming process to maintain their control over the child. And I've seen in the chat that Marilyn and I think Dr. Mamia Nyako, PML, are both saying that they don't take money for filling the police forms. Exactly. They go ahead and then treat the child, fill the police forms. In other places, the doctors complain that, what if it has to go to court? I'm now going to have to use my own fuel to be driving to courts in and out. My hospital, Hope Exchange, we also don't take money. We actually have a fund so that if it's a case that the pediatric team who doesn't take money cannot sort out, and it has to go to somebody who will take money, then we will pay from the fund for it, whatever needs to be done for that child. But if it's only the to and fro from the court, then I think that it is not beyond our hospitals, our hospital administrations, etc., to fuel that transport or the car for the person, the doctor, to go and testify in court and then come back. I don't think it's beyond them. Because if administration is going for a meeting in Kintampo and we are in Kumasi, I'll be the hospital will fuel the car. Nobody will say administrator should fuel. The hospital will fuel the car. So I don't think that it is beyond us. But it comes back to what Samuel is saying, that we need strong systems in place. We need that structure in place. When there's an instance of child sexual abuse, do A, B, C. Money must never, ever, ever stand between a child and justice. It must not. Because what it does then is that now the perpetrators get emboldened. Other people who would not have been perpetrators, he's not done anything yet. He has the potential. He hasn't done it. If he doesn't see anything being done to perpetrators, now he also becomes emboldened that even if I do it, nothing will happen to me. So the law must go through to the very end. Justice must happen for the child so that it serves as a warning, a signal to others so that they don't do same. Thank you.
Thank you very much indeed. So the thing is so interesting, and I thank God that now, as we are talking about it, we are advocating that if nothing at all, if all the doctors on this platform will begin to push that, if even my facility is taking me alone, I will not take. I believe you'll be able to save somebody along the line, and gradually you'll be able to establish it greatly. It will work. It will work. There's another point. There's another question in the chat box that. Oh, where is it, cry? Please, in cases where the family are not willing to press charges and want to handle at home, usually when the family is involved, how do we go about it, especially when there is no social welfare service readily available? Who is helping us, please? Dr. Aduma, so your hand is up. I don't know whether it's the old one or current one.
Reverend, let me put down my hand.
Okay, thank you.
Right.
Okay. Yeah, please come on. Thank you.
All right. So in situations where the families do not want to press charges, you see, some of the questions that are coming, you might not get the best answers for you straight. Like you do this or you do that, and it's a straight jacket, you have to do this, and there are no straight jacket answers like that. But in a situation like that, I think we have respected adults in the community that you can take this to, that can guide you to be there. That is one. And two, we can really work through DOFSU as well. I don't know if there are numbers that we can share, or if you have to work to a facility to find out a number of DOFSU. They'll work on it for you. And actually they work, for real. They do work. And they'll stand on it and make sure that things are done for you. So please, I think we have to either find an adult or someone they respect in the community, or they have to find contacts for DOFSU or police in order to call.
Okay.
Yes, thank you so much, Samuel. You are very right. DOFSU is very vibrant. They do a lot of work. And these days, I'm really impressed at the work they do. When it comes to even child marriages, child trafficking, they are very up and about, up and doing. So when we have cases like this of a child in which the family is not willing to pursue, or like Dr. Mami Anyako is asking about a child who's been abused by her father and the maternal relatives are quiet, what you can do is that, as Samuel said, you can find a responsible adults who may be a relative, who may be a teacher, or worst case scenario, even assemblyman. After all, why did we vote for them? For them to speak up for us, for them to speak up for our children. And then they will help this child make that case at DOVSU. And then DOVSU will continue. Now, our challenge is because our social welfare system, social welfare, if you're on it, forgive me, but let me say it as it is. Social welfare is under-resourced. They don't have cars, they don't have money, they don't have shelters. Recently, I had to keep a child on admission because I couldn't get a shelter to send this child to. She had been sexually abused by a gang of boys who had taken her out for a robbery. Aboboya drivers, you know, those small car drivers. They had taken her out, done a robbery with her, dragged her, sexually abused her, and then dumped her. Assemblyman sees her, picks her up, and then brings her, and then says that, this girl cry, she wants to run away. And she did want to run away from the hospital. She wants to run away, so he doesn't know what to do. We should let her go. He wants to go and put her in a car, and wherever the car drops her, fair enough. She's 13 years old. Social welfare doesn't have a shelter to be able to take this child, to keep this child for the night. So sometimes it's NGOs who now will come aboard and then help you, because some of the NGOs also have shelters. Let me appeal to us, Reverend. You are a Reverend, a pastor here. The church, we are busy doing a whole lot of things, raising a whole lot of money for glorious church buildings and everything. We need to build shelters for children who are being abused, for women who are being abused, for vulnerable people. We must bring together that money. Don't let me go into preaching here, but the Bible says that God wants us to take care of the poor, the needy, the vulnerable, the widows, the orphans, and he will bless us, and his glory will be our rear guard. Then our lights will shine like the day. This is what God says in his word. But we are focusing all the money on building the beautiful and glorious auditoriums with highfalutin decor and lighting, etc., and leaving these vulnerable ones. We need shelters for these ones. So back to my point, let me stop preaching. Sometimes you can get an NGO.
Clap for you.
So sometimes you can get an NGO to come in and then support you. The NGO will, let me say, lead the child to DOVSU, make the case, etc. So if you're in a place where you don't have social welfare, you do have DOVSU. You can get even a counselor within the hospital who will now lead this child and then get justice done for the child. In some cases, one instance, the girl that I shared with you in the beginning, Vera, her parents had divorced and they were both abroad. So they had shipped her to Ghana to stay with family friends. And that is where the abuse happened. So what social welfare DOVSU did was that they now found a relative who was a slightly older woman who was willing to take this child in. And then that woman took this child in, because you know that institutionalization, putting them in homes, is actually not the best that we want for these children. So sometimes they are able to find a relative who can take this child in. Thank you.
Thank you very, very much. I love the preaching aspect. I think you have to drop a momo line. Somebody will send an offering. Oh, that's beautiful. So I think our time is almost up, but let's take this last question on the chat. Then you'll be paving way for Madam President to give a few comments. Then we will go for our announcement. And I think
Reverend, please remember, I also have one question for Dr. Nelly.
Oh, is it in the chat, or you're going to ask it?
Oh, I would ask it.
Okay. Then after this, then you come and say this, that. How do you handle a case of a female teenager being abused by her father or stepdad, but mom or material relative who know about it are quiet? How do we handle a case like that? You are fortunate to know this, but the mother is saying, no, we don't want anybody to talk about this. What do you do? Who is helping us? Hello, who is helping us?
Yes, Reverend. I think that I touched on that briefly in my previous statements. Yes, that you bring in sometimes you can bring in an NGO, sometimes you can bring in a responsible adult, a teacher, etc., who will take the hand of the child to lawsuit to make the case.
Exactly. So we can.
I realized somebody has also asked why or whether families should be allowed to settle these issues at home. They should not be. And I've seen one or two lawyers whom I love who have actually taken the parents on as well, because you're obstructing justice. So they have actually taken the parents on as well for standing in the way of justice. So it is wrong for these families to hold or to settle these cases at home. It's just that, unfortunately, like I said, social welfare is sometimes under-resourced to be able to be taking the child in and out to court and actually go the whole 9 miles. So now let me just quickly ask Dr. Nelly my question.
Exactly.
So Dr. Nelly, how do we as Ghana, a country, put in place strong policies so that our children are protected, but we don't lose those benefits of our culture? Because realize that in certain countries, it's so bad such that you cannot even discipline your child because of child rights issues. The police will come and take you away or take the child away. How do we maintain that fine balance between becoming a very child-friendly and child-protective society and not tipping to the other side, maintaining the benefits of our culture? Thank you.
Thank you. This is a direct question, so please, moderator, talk to us. Dr. Nelly. Oh, I don't know whether she's off. Dr. Nelly. Oh, I think we've missed her. But can somebody else come in?
Hello? Can you hear me?
Yes, we can hear you. We can hear you now.
Right. I'm sorry. I was responding to Dr. Aduma's question. That is something that has been bothering me for at least 15 years. And the simple answer to your question is charity begins at home. Okay? Charity begins at home is that every household should be aware that yes, child abuse does happen. Yes, we must protect our children from home. And yes, we must teach them. And there's definitely, I mean, the world has moved on. Certain cultural things that we have to abandon, discard. This business of, oh, you can be my wife, we are marrying, and all that sort of business that this MP said is wrong. And we must teach children to know that it is wrong. There's children's right, but they should be coupled with responsibilities as well. Now, there is a nursery in this area where I live that they are teaching them in nursery. And when I say nursery, up to the age of 5 and all that, when they start talking to them about, toilet training, etc., they teach the children that what's in your pants is yours, and you're the only one who is allowed to have anything doing with that. And you should also not interfere with other people's panties, period. This is for very little children. It's an area that we should start from the beginning to actually teach the children too, that things happening to them that is inadvertently not right should be exposed. I know it's difficult when you're being threatened that your mother will die and this and all that, but we need to empower the children right from the beginning. That's what I mean by charity begins at home. Yes, there are areas like in Norway where you're not allowed to hit your child, etc., etc. Well, has that improve their situation. Things have improved in the sense that it's a calmer society. Our society is not run. I'm a firm believer that people are aggressive because they're being beaten right from the age of 18 months onwards. So they learn this and they grow up becoming aggressive. Maybe we should be teaching the mothers and the children together to lessen aggression and so on. It's a tall task, very big thing, but we've got to start small from somewhere.
Thank you very much indeed.
I'll be quite happy to talk to you, Dr. Poku, at some point, how we can bring in, because we can bring in principles that can be taught or used in any setting, whether it's government setting or private setting and all that. Yeah.
Okay, thank you. Thank you so much, Doc.
Thank you very much indeed. It's a tall thing that we are building, and each and everyone has a part to play. Each and every. So what you are putting in today is waiting for us tomorrow. Whatever we are putting in as a pastor, as a health worker, every aspect we are putting something in is waiting for us tomorrow. Thank you very much. Because our time is up, we want to go back to our president who gave us the introduction. Dr. Hilda, you're welcome to give us a few words before we go to our announcement by Dr. Gabriel. Thank you.
All right, thank you very much. Very interesting discussions over there. I just have a few comments that I'd like to share, also working in the child protection space. Now, I didn't hear much about differentials, but there are times when it's not always child sexual abuse. There are times when it may be something else. So if the child has a urethral prolapse, for example, you might think it's child sexual abuse, but it may not be. So we need to emphasize the importance of taking a very good history, interviewing the child aside and the parent aside as well, to hear more and allowing the child to speak in his or her own language as much as possible. Again, like she said, we are seeing the boys as well. So we still have many more females coming in, but the boys also are coming in. And we know that it is actually common. It is not rare in our environment. There's a lot of underreporting for all the reasons that they have said. So we all should be high alert in the OPDs and wherever we work, because if you don't look for it, you may not find it even when it is there. And also to take note that the perpetrator may be the one who has come with the child. So whoever that caregiver that brought the child in may actually be the perpetrator. And especially when you have situations where the living arrangements, maybe there's a stepfather, there's a fiancé or fiancé, or somebody other than, or there's a problem with the marital relationship, that also causes a lot of problems and exposes the child to child sexual abuse. Then on the issue of the filling of the police forms, at the Korle Bu Teaching Hospital also, I'm happy to say that we do not take money when we fill the police forms for the children. And the suggestions that Dr. Adoma made are all very plausible and things that we can do. Some years ago, UNICEF also mentioned in discussions that it's one area that they would be very happy for us to push for, that all our members and other doctors do not take money from children when they fill these police forms. So I would like to re-emphasize that point, that we are pleading with all of you not to take money from these children. And then also to remind everybody that because of how common this issue is and how important it is to us, that is why we initiated the Child Protection Month, which we usually will start off from the 25th of November with the 16 days of activism against gender-based violence, and then into December, also around the time when children are on vacation. So would want everybody to get involved and help us with the education in the various media houses across the OPDs and everywhere, because If it is one child that is being brought to be seen by the doctor, the other child that the mother may be carrying may be a child who is being abused, but the child is not presenting to hospital that day. So let's encourage the education to continue. Thank you all very much. And thank you to the social pediatrics group as well for organizing this for us. Thank you.
Exactly. Thank you too. We are very much grateful. And without much ado, you call on Dr. Gabriel Obeng Franton to give us the announcement and a closing remark. Please, is Doctor around, Dr. Gabriel? Hello? Hello, Dr. Gabriel, please, are you with us?
Hi, Reverend, this is Jocelyn.
Okay.
If we are unable to get her, I will just give an announcement. We are going to have a panel discussion continuing this topic tomorrow at the same time, 4 to 6 p.m. And we'll encourage everyone to join in. We are inviting the general public, so we can share the link, which will be shared on our platforms very soon, so that you invite as many can handle these situations in our country. Thank you.
Okay, thank you very much for the announcement. And as you said, we are also going to try our best to share the flyers for others to join, God willing, tomorrow, so that this will not be kept in our pocket. And I believe that with the knowledge we are acquiring today, we are going to ensure that it's put into use and it's going to bring more healing to the traumatized ones. It's going to help us very well. Thank you very much for coming on board. Unfortunately, how we started, we did not commence with prayers, but I'll plead for us to pray and close up. So we pray. Our Heavenly Father, we are very much grateful on today for another opportunity given us for us to gather here, different cadres, different group of people all coming on board to deliberate on this. We pray that you will empower us so that our voices will indeed be heard in all angles. You will break through barriers, save those who need to be saved, so that at the end of the day, we will indeed contribute greatly to our generation and the generation to come. We know we are building tomorrow, and we pray that we will not put in anything that will tend to jeopardize our end tomorrow. So, Lord, help us. We pray that you continue to bless our facilitators as we look forward to gather once again tomorrow. Help us so that we all will come on board again and receive your total outpouring. We thank you. We bless you for the organizers as well. Long live this group, and may we continue to be equipped to give the best to our society and our generation. This we ask through Jesus Christ our Lord. Amen.
Amen.
Yeah, so God bless you so much for coming on board. God willing, tomorrow, exactly 4 o'clock we start.